So, what are we looking at? Nils, tell me what we're looking at.
Hey, so what I'm showing here is a case of a patient who underwent upper GI surgery for cancer, and this is a follow-up exam that we acquired within clinical routine. So it was a standard CT scan with the questions of tumor recurrence or metastatic disease.
So they weren't having belly pain, they weren't looking for something specific.
That's interesting that you mentioned that, because when we read the exam, it was like history of upper GI of esophageal cancer following esophagectomy and gastric sleeve. That's it. Follow up.
Okay.
This was the information that we had at that point.
Because we always get very little information in these clinical histories.
I mean, you have to put it in manually, right? So it takes some time.
And we're detectives.
So
what did your detective work show you?
So what we fortunately found was that there was no recurrence of metastatic disease, no local recurrence. The exam underwent without any concerns and any conclusion. I mean, any bad conclusion or a relevant conclusion. So this is how we pulled up the first report, sent it back into our hospital health system. And then there was this tumor board where we discussed the case, where we rediscussed every case for patients with cancer history. And what was found there was that they mentioned, hey, but this patient, he had upper GI. So is it possible that how you pull the gastric sleeve through the diaphragm, and this might cause stenosis, it might cause some issues, especially following food and eating and drinking and so on. And they mentioned, does this appear too narrow on the image?
So this is information you didn't have at the initial part.
Not at all.
Retrospectively, you were able to go back and take a second look at the images, it sounds like.
That's what we did
the tumor.
During the tumor board. So what I did, I personally only look at 55 kV images. You know, these low kV images that boost the contrast, that give you a better signal to noise ratio, that avoid a lot of noise, and that you just get the better image, basically. So that's the image that I look at only in my clinical reading, and so this is the image that I pulled up in this tumor board. Okay. And this is what's shown right below the conventional image, so it's the lower left image that you see over there. Yeah. And what you see and can clearly identify is that there's something going on within the gallbladder.
Hypoattenuation.
The hypoattenuating lesion within the gallbladder, right? It's clear, to me it is still invisible on the conventional image, but when you then look at the electron density map, that's the image in the lower row in the middle, or at the Z-effective map, which is shown in the color-coded image on the very right, you see that there is clearly a sign of something that's going on within the gallbladder, and this is completely consistent with the gallbladder stone, or call it cystolithiasis as we call it, and would also explain for upper stomach pain following food and drinking or eating. So in this scenario, the spectral results help to get the right diagnosis without doing any additional exam, right? Just because with a precise clinical history, that's definitely helpful. But then with the power of these multiparametric images, you can get your diagnosis first time right. And so that's clearly a helpful case. And what I like best about it is that it's still, I usually said, I mean, you have been working with Spectral for the past 8 years by now, 10 years, close to 10 years actually. And I always say that Spectral doesn't make the invisible visible, but in this case, this doesn't hold true, because
it does in this case. I mean, looking at the original scan, you're hard pressed to see anything in that gallbladder lumen.
It's obscured.
It's very obvious.
Completely apparent, right?
Yeah.
And this is, I think, one of those ways how we see that if we look at spectral results systematically, and if we embed them into our routine reading, how spectral can make a difference for single patients and for healthcare delivery to patients.
What excites you most about spectral CT?
So spectral CT allows us to get quantitative results, and moving and bringing these quantitative aspects into the clinic and into patient care is something that I think is very, very exciting, and definitely something that will keep us busy for the upcoming years.